go ahead and get back into chemotherapy-induced nausea and vomiting. Mackenzie's got your ices, so if you didn't get your ice yet from Dr. Brown, you can just leave the rest of it here if you want to. All right, so why do we vomit? Real simple, because you guys have had the patho of this and patho presumably and also in the GI, but why do we vomit? Well, because it's toxin, right? So your body ingests toxin, your GI tract says this is not supposed to be in here, and then you throw up, right? That's basically the pathophysiology of vomiting, all right? So that's why we vomit with chemo, but the question is, why does our body sense that there's a toxin in our blood, right? Usually, you start to get nauseated as soon as if you swallow a noxious substance, you start to get nauseated right away before it enters the bloodstream. So this is a picture of methotrexate. And what happens is it will stimulate these peripheral mediators. So the big one is serotonin, so 5-HT, that's released from enterochromatin cells in the GI tract. They also release neurokinin-1, sometimes also called substance P. And via these nerves, peripheral nerves, 5-HT3, serotonin, or 5-HT, serotonin, and neurokinin-1, will directly stimulate the brainstem, the nuclear tractus solitarius, a variety of receptors. So our 5-HT3 receptors, our NK1 receptors, dopamine receptors, and acetylcholine receptors. And if you're good pharmacy students, you're already thinking targets of drugs, all right? But methotrexate will also stimulate the chemotherapy trigger zone, which is now called the area postrema, same receptors, and then the central mediator in the CTZ also communicates to the nuclear tractus solitarius. And then the result here is this autonomic response, this autonomic nervous system response of vomiting or retching, right? So that's how all this happens, all right? So you can see to some extent that the first place that we can block this process is here, okay? Because if we block it before it gets to the brain, then we probably have a better chance of stopping it from happening, okay? So let's talk about serotonin. So this is serotonin's role in acute chemotherapy-induced nausea and vomiting, right? So what we have here are change in the ratio of 5-HIAA, which is a metabolite of serotonin, to creatinine in the urine. So essentially what we're looking for is urinary excretion of serotonin, okay? That's what's measured here, okay? How much it goes up. With cisplatin plus cyclophosphamide, okay? So you can see here that serotonin in the urine peaks 10 hours after a dose, okay? So serotonin is a huge mediator of acute chemotherapy-induced nausea and vomiting, right? Now this is looking at vomiting intensity, and what you can see here, if you go back to this slide, look at the screen, don't look at your notes for a second. Change in urinary excretion of serotonin, vomiting intensity, right? If I just went back and forth real quick, you couldn't tell which slide was what because they're perfectly parallel, right? So what that tells you is this is serotonin that's causing this acute nausea and vomiting with cisplatin. However, if you plot vomiting intensity with cisplatin, you see that green line right there that parallels the urinary excretion of serotonin, but then there's this bump right here, okay? So this cisplatin vomiting intensity is serotonin, right? It's serotonin. But then the serotonin is gone, and we get this second bump right here, say 2 to 3 days later. This is our delayed nausea and vomiting, okay? So that's my question, is what's the cause of this? What's the cause of cisplatin's delayed nausea and vomiting? Is it serotonin? Is it the serotonin metabolite, 5-HIAA? Is it enterohepatic recirculation of cisplatin? Or is it something else? Well, the serotonin metabolite is gone by the time we get this bump in vomiting intensity. So it's not the serotonin metabolite. And if it's not the serotonin metabolite, it can't be serotonin. And if it was enterohepatic recirculation cisplatin, we'd probably get more serotonin released. So it must be something else. It must be something else. Yeah, it's something else. So what causes this? This is neurokinin 1, or substance P. Okay? That's what mediates delayed nausea and vomiting. Now, NK1 is also present, it's also involved in acute nausea and vomiting. Okay? So now we have two neurotransmitters, serotonin, neurokinin 1, they're involved in acute nausea and vomiting, but only neurokinin 1 is important of those two in delayed nausea and vomiting. So, we have acute nausea and vomiting here in red, so we have serotonin, neurokinin 1, also a factor, and then for delayed nausea and vomiting, we have neurokinin 1 as the main predominant factor for causing delayed chemotherapy-induced nausea and vomiting. Ondansetron is a 5-HT3 antagonist, and aprepitant is a neurokinin 1 antagonist. So what would be the best way to use these drugs to prevent cisplatin-induced nausea and vomiting? Give both on day 1. Give ondansetron on day 1 and aprepitant on days 1 to 3. Give ondansetron on days 1 to 3 and aprepitant on day 1. Or give both on days 1 to 3. Perfect. Ondansetron on day 1, then aprepitant on days 1, 2, and 3. Now, if you do option D here, if you give them both on days 1, 2, and 3, you're not going to get any better control of nausea and vomiting. You're not going to hurt anything necessarily by giving a couple extra doses of ondansetron, but general principle is we only give the drugs we need to give, okay? And we don't really get any added benefit from a 5-HT3 antagonist on days 2 and 3, assuming all chemo is given on day 1. Start giving chemo on days 1, 2, and 3, it throws things off a little bit, okay? Good, so you guys know what the guidelines are going to say. So, drugs. This will be kind of fast because you guys have probably talked about all these drugs before. So if there's a drug on here you're not familiar with, just please stop me. But we have drugs acting the frontal cortex, we have our dopamine antagonists, we have our serotonin antagonists, and then we have other. And I've highlighted the ones we'll talk the most about. Just as a general rule of thumb, our dopamine antagonists, you can classify them based on their chemical class. I like to think of them as their pharmacologic class, which is blocking dopamine. Okay? And in general, if you're going to use a dopamine antagonist, you just use one. You don't use multiple, even if they may be in a different chemical family. So this is how things have gone, and why we have that perception that everyone getting chemo is going to vomit. Because when we first started giving chemo in the 60s, we didn't have a whole lot. We had things like, like promethazine, not great at blocking dopamine. And then in the early 80s, we gave high-dose metoclopramide. Now, at normal dose of Reglan would be 5-10 milligrams. At normal doses, it blocks dopamine. At higher doses, it blocks serotonin. And when I say higher doses, I'm talking like 1 mg per kg. 80 milligrams of metoclopramide, not like 5 milligrams TID for gastroparesis. 80 milligrams, really high doses of dopamine. That was our standard of care in 1983 when you saw that vomiting was the #1 side effect that distressed people. And then we get ondansetron in the early 90s, and then we get aprepitant, and then we discover how effective olanzapine is, the antipsychotic. All right, so first things first about the 5-HT3 antagonists, they block the effect of serotonin release from the intrachromatin cells. So they have a peripheral mechanism, and then centrally they actually block serotonin receptors, the 5-HT3 receptors in the medulla. Big side effect here is headache. All right, it's not a big side effect, but it's a common side effect. And if somebody has a headache with one 5-HT3 antagonist, we typically change them to a different drug within the same class, and the headache can go away. What a lot of people worry about with ondansetron is QT prolongation. And I'm here to tell you, it's not an issue. It's not an issue in the doses that we use. The QT prolongation we see with ondansetron was seen at doses of 32 milligrams, and if it's given in high doses, IV push. If you give 8 milligrams IV, we give it over 15 minutes, and we don't have any concerns with QT prolongation. Okay? where you're talking about a one-time dose before chemo. Not worried about QT prolongation with ondansetron in the slightest 99% of the time. Okay? But it's a side effect that people expect you to know of ondansetron. Okay? But it's one that clinically is not that problematic. All right, so if we compare these, I've grayed out dolosetron because it's not available on the market. All right, and I've highlighted in green the two that we use the most. So ondansetron, brand name Zofran, and palonosetron, brand name Aloxi. So you can see here that one of the big differences is that palonosetron has a half-life of 40 hours. So very long half-life. So if you give a dose of palonosetron, it's like giving a dose of ondansetron on days 1, 2, and 3 because it has such a long half-life. Okay, that's one difference. Longer half-life. Another difference is palonosetron doesn't have any QT prolongation. Quote, no significant effect is what the package insert says. Whereas with ondansetron, at the doses we use, you have a 5.6 millisecond prolongation of QT interval. If that was a new drug coming out today, that wouldn't even make it into the FDA label. Now you kind of have to prolong the QT interval by 20 milliseconds for that to be considered significant. Okay? But you can see at 32 milligrams at the higher dose, we did see almost a 20 millisecond increase on average of QT interval. Okay, this is kind of historical background information. There's a podcast about this that goes in a lot more detail. Just to point out how good ondansetron is. This is a landmark study, and this is number of emesis episodes. We're up here in the 50s here. These are people that got high-dose metoclopramide for 8 hours. And you can see really no difference. You're talking 50 episodes of emesis over several hours, over like 5 or 6 hours. That's a lot of vomiting. Zofran. Really high-dose Zofran, an 8 milligram loading dose, then 1 milligram an hour. These people got like 32 milligrams of Zofran in a day. Big dose. And look how flat that line is of emesis. Okay. Zofran is not just better than high-dose metoclopramide. It is way better. Okay. Huge magnitude of benefit here. Okay. So ondansetron was really changing, right? Incredibly practice changing. Now therapeutically, we use these interchangeably. Whatever is cheaper for the patient for day one doesn't make a difference which one you use. Oral is as good as IV as long as they're dosed equivalently. And a single dose is effective as multiple daily doses, even though the guidelines suggest or say we should do BID dosing of ondansetron. These are the standard of care to prevent acute nausea and vomiting with moderately and highly emetogenic chemo. They are synergistic with corticosteroids. I have a little image about that later on. Now, they're not as effective for delayed nausea and vomiting. In fact, they're inferior to dexamethasone or prochlorperazine at treating and preventing delayed nausea and vomiting. And the QT prolongation risk is rarely a concern. It's an IV thing, it's a high dose, it's a concentration-dependent effect. You give a high dose IV, you'll see some QT prolongation. Corticosteroids, the second most important drug we use in CINV. Do you guys know how these work for chemotherapy-induced nausea and vomiting? Because if you do, I'd love to know. Because we don't know. We don't know the mechanism of action for chemotherapy-induced nausea and vomiting. But dexamethasone is the drug that we use. 20 milligram is the max dose. And you guys know the adverse effects of dexamethasone. So here's an example of, at the bottom here, the complete response rate, which is usually defined as no emesis and no use of a breakthrough medication for nausea. Okay? So complete response rate, 64% with ondansetron, 91% when you add dexamethasone. Okay? So Dex, they're synergistic with neurokinin 1 or with a 5-HT3 antagonist to prevent both acute and delayed chemotherapy-induced nausea and vomiting. And if you don't do a good job preventing delayed chemotherapy-induced nausea and vomiting, if you don't give them Dex, say on days 2 and 3, then you can use Dex to treat it as well. And then a neurokinin 1 antagonist. Yes, question.
So if we use corticosteroids, wouldn't this lower the immunologic agent?
Are you saying are you worried to be immunosuppressive?
Yeah.
Yeah, it would be a little bit immunosuppressive. Now, usually that immunosuppression is a concern with long-term use. Not, we're talking about taking it for 1 to 4 days. So it likely doesn't have a big effect on that. The bigger effect about patients are some of the trouble sleeping, and then staying up late and stuff like that, or increases in their glucose. What patients tend to say when they get chemo is they actually feel really good the day they get chemo and then a couple days after they get chemo. Because if they get Dex for 3 days, they feel great for 3 days, and then the dexamethasone stops and they feel like they hit a wall. That's usually what people complain about with treatment. Yes?
I was wondering, is the dexamethasone a good way to not use the aprepitant?
Question is dexamethasone a good way not to use aprepitant? We'll talk about that. It's a good question. All right. The third most important drug are neurokinin 1 antagonists. So this is aprepitant. They have that role in both acute and delayed CINV. Very effective, very safe, pretty costly drugs. So we kind of use them, again, interchangeably based on cost and their drug interaction potential. And there are some differences in half-life here as well. I'm going to kind of try and walk through these. So in general, we have three chemicals. We have aprepitant, which is available as aprepitant, and then there is an IV prodrug called fosaprepitant. There's natupitant, which is only available co-formulated with palonosetron, the 5-HT3 inhibitor, and then there's rolapitant, right? And I've highlighted some differences here. Now the dosing, of course, is different. I want to point out that rolapitant has a 7-day half-life. You have one dose covered for a week. Very long half-life, okay? You can see here that aprepitant is a 3A4 inhibitor. And that's going to be important because dexamethasone, one of our backbone drugs to prevent CINV, is a 3A4 substrate. So there is a drug interaction between two of our three most important drugs, aprepitant and dexamethasone, which is going to affect our dosing. Okay. Natupitant, also a 3A4 inhibitor. Natupitant is about the same level of inhibitor as aprepitant. Rolapitant is not a 3A4 inhibitor, but it is a 2D6 inhibitor. Right? So, the way oncologists look at this is they just give whatever. The way, as an oncology pharmacist, I look at this is, are we worried about drug interaction with these things? And I'm more worried about drug interaction with rolapitant. 2D6 has fewer substrates than 3A4. But aprepitant, you're giving it for 1, 2, 3 days. It's got a short half-life. Whatever drug interaction is with aprepitant is going to be out of the system within a week. Rolapitant, that's not going to hang around for a long time. That drug interaction will persist for at least a week. And some of these 2D6 substrates are pretty potent. Okay. Talk about some opioids. We're talking about a lot of neuropsychiatric drugs that are 2D6 substrates. So that's one that is concerning. But one of the takeaways here is you should screen for drug interactions anytime somebody's getting a neurokinin 1 antagonist.
So did you see that dexamethasone is a 3A4 substrate?
I did. 3A4 substrate. Okay. So if we look at overall complete response rate with aprepitant versus control, and this is, again, these old studies use high dose ondansetron, and by the way, no one died from torsades, right? Along with a dexamethasone or aprepitant, okay? So you can see overall, you have a benefit. This is a delta of about 20% in the overall, but it's, a mild benefit in the acute, a little bit larger benefit in the delayed section. Again, so neurokinin 1 has an impact on acute and delayed nausea and vomiting. And this is with cisplatin-containing regimens. Okay. Again, pretty big improvements there in our overall complete response rate. If we talk about giving, not with a cisplatin, but an AC regimen, one thing to look at, first of all, we're talking 50% complete response rate in the overall setting versus 70% up here. Okay? What would that be? Cisplatin's higher metagenic than AC. So why do we have lower CR rates, even with aprepitant? It's all breast cancer. They're all women. Remember, female gender, risk factor for chemotherapy-induced nausea and vomiting. Also notice, in these studies, in the cisplatin study, they gave dexamethasone for 4 days. Long-term dexamethasone. Here, dexamethasone was only 1 day. So if you go short on the dex, you're probably going to have more nausea and vomiting. But still, some benefit here. So we do use aprepitant with our breast cancer patients. So you're already hopefully starting to see what the guidelines are probably going to look like. For our very highest risk patients, you're going to have ondansetron or another 5-HT3 antagonist, dexamethasone, and a Prepitant. And the Dex and a Prepitant should last for a couple days afterward to prevent delayed nausea and vomiting with cisplatin and with anthracyclines and cyclophosphamide. Then the last key drug is olanzapine, right? Zyprexa, which you would have heard about from Dr. Melton. So it's an atypical antipsychotic, and you can see why this would be attractive as an antiemetic. It blocks serotonin receptors. It blocks dopamine. It blocks histamine as well, and muscarinic. So it blocks acetylcholine. Okay? So several of those neurotransmitters in the brain, olanzapine blocks. The dose that we use for chemotherapy-induced nausea and vomiting is 10 milligrams, days 1 to 4. And the big thing we're about is somnolence. That tends to peak on day 2 or 3. So this is what this looks like. You can see that for, again, we're measuring complete response. And all these patients receive, the standard treatment. And for acute nausea and vomiting, it was better. For delayed, it was better. Overall, it was better. So what we have now is kind of a Cadillac regimen to prevent nausea and vomiting. It's 4 drugs. The 5-HT3 antagonist, NK1 antagonist, dexamethasone, and olanzapine. Right? Now we have some other drugs to talk about. So the benzodiazepines, these are the best drugs for anticipatory nausea and vomiting. Lorazepam is the drug of choice for anticipatory nausea and vomiting. And again, that's that nausea that happens when you're nervous or scared about the fact that you're about to receive chemo, or you see something that associates you with chemo. Okay, and usually it's with a bad experience you had with prior chemotherapy, with nausea and vomiting. So our phenothiazines include prochlorperazine and promethazine. These are dopamine antagonists. Promethazine is a stronger dopamine antagonist than promethazine. So prochlorperazine or compazine is a better antiemetic than promethazine. Promethazine is a little bit more potent as an antihistamine or antimuscarinic, so promethazine has a little bit more sedation than prochlorperazine. So this is my preferred drug to treat breakthrough nausea and vomiting, is prochlorperazine. So that's the one that I usually recommend for breakthrough nausea and vomiting. And then butyrophenones, these are also dopamine antagonists. We don't use these a whole lot, so I'm going to skip over that. Cannabinoids, we don't use a whole lot for chemotherapy-induced nausea and vomiting, so I'm not going to talk about that. And there's a whole list of other antiemetics here. I'll point out I have acupuncture and ginger highlighted in bold because there are randomized controlled trials showing that those two practices are effective in chemotherapy-induced nausea and vomiting. People ask a lot about medical marijuana or CBD, and I always recommend against it. CBD, for example, has a lot of drug interactions, and there's actually an FDA-approved cannabidiol product, and you can go to the package insert and see some of the scary drug interactions with CBD. And smoking marijuana has a lot of junk in it, like fungus, and so there are a lot of case reports of people having invasive fungal infections if they smoke marijuana while on chemotherapy. All right, so summary of the drugs. Things to take away: 5-HT3 antagonists. They have headache. We can change to a different agent. Palinositron is different, that it has no QT prolongation, has a longer half-life. The olanzapine somnolence peaks at days 2 and 3, and the way that we should choose our neurokinin 1 antagonist is really based off of the half-life of those agents and are there any drug interactions to worry about. All right, so let's go through some principles. There are 5 principles. All right, you guys talk about migraine headache, right? What's the key principle in abortive therapy? Migraine headache, not preventative therapy, not to prevent migraines, but somebody has a migraine. What's the most important counseling point to a patient when they pick up their triptan?
Rebound?
No, not rebound.
Take it as soon as you.
Take it as soon as you have a headache. Why?
It's more likely to work.
Why is it more likely to work?
It blocks the histamine.
The longer the headache builds, the harder it is to treat. Same principle in chemotherapy-induced nausea and vomiting. The longer you wait to treat it, the harder it will be to treat it. So the first thing we do is we try to prevent it. Because if we don't prevent it, it's like that migraine headache, like a snowball rolling down a mountain that keeps getting bigger and bigger and bigger. This animation's taking too long. And then it's going to run over this poor guy at the bottom if we don't prevent it, okay? See? So prevention. Stop the ball from rolling in the first place. If the ball never starts rolling, if it does start rolling, we take something right away. Okay? So we want to stop the ball from rolling in the first place. If it does start rolling, you don't wait for an episode of emesis. As soon as the patient has any nausea, they should take something as needed. They should take some breakthrough medication. All right? Next thing we do is we risk stratify. Do we call these patients high risk, moderate, or low risk? So we talk about the chemo factors. So cisplatin-containing regimens and AC. That's pretty much it. Those are the ones that are going to get the highest, we consider the highest risk of metagenicity. Everyone else we kind of classify as moderate if they're getting traditional chemo that doesn't fall into a cisplatin or an AC, an anthracycline cyclophosphamide regimen. If it's high risk, we're probably going to give 3 to 4 drugs. We're going to have something available for breakthrough as needed. Whereas our moderately metagenic will give 2 to 3 drugs. And if it's lowly metagenic, just 1 drug beforehand. And then we use our individual patient factors. So the way this could work is you may have a patient who's receiving a moderately metagenic chemo, what we call MEC. But let's say this person is a young female, say a 23-year-old female, who has a history of anxiety and depression and had a baby 2 years ago and during the pregnancy period had really bad morning sickness. That's someone who chemo makes them moderate metagenicity. But because of that individual's patient-specific risk factors, we might treat that person like they're receiving highly metagenic chemo. Okay, so that's how you use those individual patient factors. Likewise, you might have a guy with head and neck cancer, a veteran, big drinker, going to get a cisplatin-containing regimen, but he's old, he's a man, alcohol abuse. That's someone, even though he's getting highly metagenic, you might downstage him and treat him kind of on the borderline between moderately and highly metagenic. Okay. Next thing we do is we anticipate breakthrough. Even if we're giving someone 4 drugs to prevent chemotherapy-induced nausea and vomiting, we always assume there might be some breakthrough, and we have a script written to have something available for breakthrough. And it should be a drug that we're not using to prevent acute. Okay? So we shouldn't use ondansetron for breakthrough acute nausea and vomiting because they're already getting ondansetron up front. Right? We shouldn't use a corticosteroid to treat delayed nausea and vomiting if they're already getting a corticosteroid on day 2 and 3. And we tell patients, just like you would tell someone picking up their Imitrex, take it at the first sign of a symptom. Don't wait to see if it's going to get better on its own because it's only going to get worse and harder to treat. If the breakthrough keeps happening, don't just wait for the nausea to come back. Have them take their breakthrough medication scheduled till they're out of that 5-day window when all the delayed nausea and vomiting should be gone. And then we reevaluate each cycle. Right? So our goal is 0 episodes of emesis. If you give someone 3 drugs to prevent chemotherapy-induced nausea and vomiting, and after cycle 1, they have 1 episode of emesis, you got to change something. With cycle 2, you got to add a 4th drug or do something different. And if you're using a whole bunch of breakthrough medication after cycle 1, then maybe you should do something different for cycle 2. Even if you don't have any episodes of emesis, if they have significant nausea, requiring them to take breakthrough meds, then you probably ought to add something else. And then we individualize. So we have guidelines that are a good starting point, but we can change things based on patient-specific risk factors. All right, so question for you. What do you think the guidelines say about preventing nausea and vomiting with highly metagenic chemo? You're supposed to write this down, though. Sorry. This is what it says. 4 drugs on day 1, and then 3 drugs for the next couple of days. That's kind of what you would expect it to look like based on what we've presented. Okay? And you should have been able to predict this from what we've been doing. Okay? Now that doesn't mean that you're going to give a neurokinin 1 antagonist for days 2, 3, and 4. Like if you give a dose of erlapitant on day 1, 7-day half-life, you don't need to give any more doses. Okay? There's no use writing this down because this is just what you should have predicted. The guidelines are on the coming pages. Okay? All right. So I'm going to talk about the American Society of Clinical Oncology guidelines. Historically, they've been strictly evidence-based, but there is an expert panel involved, and these experts have a lot of contributions from the pharmaceutical industry, and there is some opinion that goes into this as well. Another thing that I'm going to say is the guidelines all assume chemo is given on day 1 only. Okay? Not every regimen is that way. There are some regimens where you get multiple days of chemo. So this all applies to day 1 only chemo. But if you understand the baseline principles, you'll be able to take care of patients who are getting chemo for 3 days or 5 days. Okay. So this is what it looks like. High risk, give 4 drugs. And you should know what those 4 drugs are. Okay. If it's moderate, but one of those drugs is high dose, or kind of actually not high dose, but just standard dose carboplatin, they say 3 drugs. I don't agree with that. We'll talk about why that is, but that's what the guidelines say. If it's moderate, you just use 2 drugs, 5-HT3 antagonist and Dex, and if it's low, you just use 1 drug. Okay. So you have high, moderate with carboplatin, moderate, and then low. 4, 3, 2, 1. Okay. Now, it gets a little bit more complicated than that when you look at actual drugs and doses. So this is what the guidelines say for cisplatin, highly emetogenic chemo. So it doesn't matter which 5-HT3 antagonist you use, okay? But it's day 1 only, okay? 5-HT3 agonist day 1 because serotonin's effects are only day 1. And then olanzapine, 10 milligrams days 1 through 4. That's the same for everything. The dosing of your dexamethasone is going to be dependent on which neurokinin 1 antagonist you use. So if you use aprepitant, the oral aprepitant, which is a 3-day regimen, we're giving 12 milligrams of dex on day 1. Now, the 12 milligram of dex on day 1 and 8 on days 2 and 3 is the same as 20 milligrams of dex if you did not have aprepitant because of that CYP3A4 drug interaction. Okay. Now this is 3 days of aprepitant. Okay. Now if you give aprepitant, it's the IV prodrug, it's 1 day only. If it's 1 day only, notice that we still give 12 milligrams of dex on day 1, then 8, and then 8. But there's a difference here on days 2 and or on days 3 and 4. We give dexamethasone twice on days 3 and 4, and that's because that drug interaction with aprepitant leaves the body faster because we only gave 1 dose of aprepitant. Whereas the regimen above that, we give 3 days of aprepitant, so that drug interaction lasts for an extra 2 days. Okay, and the same thing goes for rolapitant. If you use rolapitant at the bottom here, that dexamethasone on days 2 and 4 is BID. Why? There's no 3 or 4 drug interaction, so we want to get closer to that 20 milligrams a day of dex. Also notice, if you give rolapitant, our dex dose is 20 milligrams because that drug interaction is not there. So we give the highest dose of dex that's effective for delayed nausea and vomiting. Okay, so the details here you can get bogged down in. But the principles, again, let's keep the big picture principles in mind. Highly emetogenic chemo, cisplatin, 4 drugs. The dose of those drugs is dependent on the drug interactions with your neurokinin 1 antagonist. Okay, that's the big picture idea. Now, if you're giving AC, this is the breast cancer regimen. Notice the guidelines are all, again, same 5-HT3 antagonist day 1, same olanzapine, whatever neurokinin 1 antagonist, but the dexamethasone is just on day 1. So this is kind of a dexamethasone sparing regimen. Why do the guidelines say this, whereas with cisplatin they have dexamethasone on days 2, 3, and 4? Because that's the way the studies were done that got these drugs approved. Okay. Does that mean if you give somebody getting AC for breast cancer this exact regimen and they have delayed nausea and vomiting, does that mean you should not give dex on days 2 and 3? Absolutely not. That's probably the best thing you can do for them, is to give them more dexamethasone. But that's one difference in the guidelines. Okay. And again, notice the dose of dexamethasone depends on which neurokinin 1 antagonist you use and whether it inhibits 3A4 or not. Okay, for moderately emetogenic, any 5-HT3 antagonist on day 1 and then dex on day 1 or days 2 and 3 with an asterisk. That asterisk is for drugs that have delayed nausea and vomiting. And the guidelines mention doxorubicin and cyclophosphamide and those other things. But I also will add oxaliplatin in there as well, which the guidelines don't explicitly mention, but they should because it also causes delayed nausea and vomiting. If you don't know if a drug causes delayed nausea and vomiting, then you probably just give them Dex on days 2 and 3 if it's moderately emetogenic. Why? Because we tend to underestimate the impact of delayed nausea and vomiting on patients, which we talked about early on. Okay, now this was a new thing to the guidelines a couple of years ago, which is to take a subsection of patients with moderately emetogenic chemo, those receiving carboplatin, and basically make it a higher dose or a higher level of control where you give them a neurokinin 1 antagonist, okay? And just give them Dex on day 1. In essence, this is like a dexamethasone sparing regimen, okay? Now, there is no study that compared a neurokinin 1 antagonist regimen to 3 days of Dex. So I think you could do either one and be okay for moderately emetogenic chemo with carboplatin. And that's what these data show. I'm not going to go through it, but just suffice to say that the control group only received 1 day of Dex. When to really have a fair comparison, you should have received 2 to 3 days of Dex, because this group has nothing to prevent delayed nausea and vomiting. They have a 5-HT3 antagonist for 3 days, but that's not going to help with delayed nausea and vomiting because there's no serotonin. It's an incredibly flawed study. And the people that did study paid some folks on the guidelines. Right? Same thing with this study. No Dex on days 2 and 3. Okay? And of course the aprepitant group is better. But is it better in the acute setting? No. It's better in delayed. Because the control group was undertreated. Right? So that is what led the guidelines to add this thing about adding neurokinin 1 antagonists for carboplatin regimens. Either one's the same. Okay, but guidelines are for guidance. Okay, so let's practice. So here we have a 57-year-old man who's about to receive cycle 1 of Folfox for colon cancer. Folfox, oxaliplatin, 85 milligrams per year. Hold on, I don't want to confuse you guys. Modified Folfox. Okay. All right, so using the ASCO guidelines, what's the ideal CINV regimen prevention for this guy? Okay. Now remember what I said. You have to know that cisplatin is highly emetogenic. Okay. And the AC we consider highly emetogenic. So you should be able to figure out, is this highly emetogenic or not? And I said if it's not highly emetogenic, just assume it's moderately emetogenic. Okay. So we do palonostrone and nitupetin that combined just that on day 1, on danzatron on day 1, and then Dex on days 2 to 3. On danzatron day 1, Dex on day 1, or on danzatron day 1, phosaprepitant on day 1, and then dexamethasone on days 1, 2, and 3. Alright, so what do you guys say? Okay. Good. Option B. So on danzatron on day 1, and then Dex on days 1, 2, and 3. Right? So this is a moderately emetogenic regimen. Right? The oxaliplatin is moderate, leucovorin is low, or 5-FU is low, leucovorin is folic acid. Right? Reduced folic acid. But oxaliplatin has the potential to cause delayed nausea and vomiting. So we should have some dexamethasone scheduled on days 2 and 3 to prevent that. But that's not enough. We also need to give this person something in the event he were to have breakthrough nausea and vomiting. So some prochlorperazine or compazine every 6 hours as needed until you're through that window where you're done with delayed nausea and vomiting. Okay? So that's what the script should look like for this guy. Okay? Questions about this? Okay, now, 47-year-old woman just been diagnosed with breast cancer. She's going to receive her first cycle of AC. The most appropriate antiemetic regimen for this patient. And again, let's assume she has no additional patient-specific risk factors. Okay. So, our options. On danzatron, on day 1, aprepitant, days 1, 2, and 3. Dexamethasone, days 1, and then a lower dose on days 2 through 4. Ondansetron twice a day on days 1 through 4. Aprepitant for 3 days, and olanzapine for 4 days. Palonostrone nitupetant plus olanzapine. Or palonostrone on day 1, fosaprepitant on day 1, dexamethasone on day 1, and olanzapine on days 1 through 4. Let's see what you guys say. All right, good. 4-drug regimen. Only one of these options has 4 drugs. Okay. Now, I'll tell you that before the olanzapine study came out, this option would have been what would have been recommended. And you will still see a lot of people in the real world that get a regimen like this with AC. Because even though the guidelines say to give the 4-drug regimen for AC and for cisplatin-containing regimens, the uptake and adoption of those guidelines has not fully caught on. Okay, next case. Here is a 64-year-old man receiving cisplatin and gemcitabine for lung cancer. He had 1 episode of emesis following cycle 1. Right? So on day 2 after cycle 1, he threw up. Right? His past medical history is significant for Parkinson's disease and type 2 diabetes, both of which are controlled on medications. So prior to cycle 1, he got 8 milligrams of Zofran before chemo, Dex 12 on day 1, then 8 on days 2 through 4, and aprepitant 125 on day 1, and 80 on days 2 and 3. So what change should we make to his regimen in light of the fact that he had 1 episode of emesis? Add olanzapine, change ondansetron to palonosetron, add prochlorperazine, or no change. Alright, let's see what you guys say. Add olanzapine. Okay. Reasonable. Very reasonable. What might be the downside of adding olanzapine? He has Parkinson's disease, right? What do we give for Parkinson's disease? Dopamine. How does olanzapine work? Blocks dopamine. So giving olanzapine will probably make his chemotherapy, and it will work. He won't have any episodes of emesis most likely. His Parkinson's might get worse though. Now, you add prochlorperazine, that's also a dopamine antagonist. It's a weaker one, but you might have the same issue there. Okay. Changing ondansetron to palonosetron probably would not help. So the best answer here might be like cannabidiol, or it's not been tested, but dronabinol, the Marinol, or something that has a different mechanism than that. It's not a dopamine antagonist. Okay. So don't discount their home meds here and this sort of stuff. Yes.
So if the prochlorperazine was, could we use that one for breakthrough also, right? So it wouldn't technically be scheduled necessarily. It could just be added on for breakthrough. Would that still help, or are you adding something on that's scheduled?
So if somebody has an episode of emesis, then you would want to add something that's scheduled. Now that's assuming they already have something for breakthrough that's already at home. But you could add prochlorperazine scheduled as well. You could have someone take it every 6 hours from days 1 through 3 or 1 through 4. Okay. So from a purely chemotherapy-induced nausea vomiting standpoint, if you took out all of his past medical history, adding olanzapine is the best answer here. But then if you throw in this history of Parkinson's, makes you wonder a little bit, is that the best thing to do? There's really not a great option in this scenario because all of our breakthrough drugs that we use or anything else you would add is going to block dopamine as well. Okay, so, summary. The guidelines are kind of your starting point here. And again, big picture, remember the big picture first. High risk, 4 drugs. Moderate risk, 2 to 3 drugs, depending on if you buy that data about adding and neurokinin 1 antagonist for carboplatin. Then other moderate risk is going to be 2 drugs. Okay. Know what the risk factors are for chemotherapy-induced nausea and vomiting, both drug-specific and patient-specific. Understand that we're trying to prevent this from happening. That's why we give all these drugs in the first place. Think back to that figure of number of episodes of emesis before we had Zofran. Okay. We do a really, really good job preventing this from happening. But we only do a good job if you really understand these principles of it. Which is why I spent more than an hour going over something that you can just look up the guidelines in like 3 minutes and figure out what to do. And the reason for that is anybody can look up the guidelines. It's when patients have Parkinson's disease and they can't receive a dopamine antagonist. It's when they end up in DKA because they got too much dexamethasone. You got to figure out what to do. It's when the chemo regimen is cisplatin for 5 days and the guidelines don't apply. They have to figure out what to. You have to understand these principles to know what to do. Okay. So when I get back to my office, I got 2 D12 quizzes to turn on. This CINV has a pool of 15 questions. Okay. And there was a question I got about, are the things cumulative? And life is cumulative. Okay. So just like this, you might have a question like this Parkinson's. Like, I'm not going to teach you about Parkinson's. You already learned that. Or you already taught it. Okay? Hopefully you learned it, because that stuff can come back up. Right? I don't want you to be experts in treating cancer. I want you to be experts in taking care of people with cancer. You're not going to be deciding what the chemo regimen is. You're going to be helping make sure the chemo regimen goes as smoothly as possible. And this is first and foremost in chemo going smoothly, is stopping nausea and vomiting. Okay. I told you guys, great week. See you tomorrow.